Welcome to this interesting Aspire podcast, where we will be having a dialogue with Professor Richard Anderson about premature ovarian failure. Before we discuss about the regenerative medicine approach, can I ask you, sir, briefly, can you tell me premature ovarian failure, how it is different from menopause, and briefly about the factors affecting it?
So the terminology, I think, here is very important, and we discussed in the previous 5 years ago the version of the POI guideline from ESRA that we wanted to really promote the use of the term premature ovarian insufficiency as being the appropriate, because there was a lot of patients find the term failure really unhelpful and really a problem for discussing, and probably more clinically relevant as well, because of course, in many of our patients that we see a bit of ebb and flow in the situation. It's not like a black and white, the ovary is completely not working and doing nothing. And so is to recognize that. And of course, the prematurity is the essence of the issue. And the terminology primary has often been used here, but primary ovarian failure happens to all women. That's the natural menopause. And so we felt that premature was the key aspect of that. So that's how we settled on that terminology, which is now increasingly used even in North America, which is fantastic.
Thank you. Thank you, sir. So can you now highlight more about when we are talking about inefficiency? It means there are certain hopes and we can regenerate this ovary. So can you tell me the role of regenerative medicine? Where are we today in the role?
So it's an exciting area, isn't it?
Yes, very
the
exciting.
possibility. Because, of course, many of our patients at the time of diagnosis of POI are trying to fall pregnant or have wishes for the future. Of course, this is affecting teenagers as well as young adult women. And so their future fertility is really important. And we know that there is a chance of fertility for some of these women. The literature suggests it's perhaps in the region of 5%, maybe a little higher. There's a very nice French study that shows it's higher in younger women than older women, as you might expect. But it's very unpredictable, and ovulation may occur sporadically. So if we had an approach to try and use those follicles that we know still are there, then I think that would be really useful for our patients.
So what you do in your practice, can I ask you, if the patient of 33 years come with the POI, how to proceed? And she's not interested in any egg donation approach.
Well, I think that's a real challenge, because I think we don't have established approaches to this. We can certainly discuss ones that are in development, and there are a whole range of exciting therapies that may become available. But at the moment, I don't offer any specific therapies for such patients, because I don't think there's robust scientific evidence to really support them. There's anecdotal evidence, but I think that something we could perhaps discuss is the areas that look promising, but we really need better evidence to really, if we're going to advise our patients to be going down that road. So in the absence of egg donation, I think we're struggling a bit to really find something concrete and valuable to offer our patients.
Thank you. Thank you for letting us know that. So is there any medication you would like to think about?
So I think one of the key issues when we're discussing with these patients is whether they are really estrogen deficient and needing some therapy there. And of course, conventional HRT, especially when given in a cyclic manner, isn't going to be contraceptive. And so if a patient is struggling with symptoms, with vasomotor symptoms, for example, then giving a relatively low dose estrogen may be helpful in terms of maximizing their chances of conceiving and maintaining some endometrial regularity that may help with that. And there is a suggestion, and in fact, from a study from a number of years ago in Italy, that a well-performed RCT, that actually a low dose of estrogen and slightly normalizing the FSH perhaps may actually enhance fertility in women with relatively early onset POI. But I think that really needs to be substantiated.
That's a different way of thinking. What do you think about the role of DHEA or testosterone gel like?
Yeah, so I think that's something that's coming to fruition in terms of a more robustness of evidence at the moment. And I think there are interesting aspects as to why it might be beneficial, but the bigger trials now coming out, unfortunately, do not show a benefit. And we await the big European trial, the T-Transport trial that Professor Polozos in Barcelona, Barcelona, led on, that he's only, I think, so far presented as an abstract at last year's ESRA meeting. But they very clearly showed, unfortunately, that testosterone gel treatment in the regimen they were using was ineffectual. So it's disappointing because I think, other approaches to enhance follicle development may be valuable in the future. And I think we certainly shouldn't give up on trying to address those questions. And perhaps we can have a think about and discuss other therapies that might be over the horizon at the moment that come into that category.
Thank you. So I do understand for a regenerative therapy in form of stem cell therapy or PRP, there is no robust evidence, but there are many publications. If we go on a clinicaltrial.government site also, we see many enrollment of many organizations or the institutes working on it, and there are many publications of it, the stem cells therapy coming up. So do you think if the robust evidence, how long it will take for us to think that, yes, we can help with the regenerative therapy in the form of autologous bone marrow derived or the adipose tissue derived mesenchymal cells?
Yeah, so these are really interesting approaches, aren't there? And there's some really fascinating preclinical data suggesting that they might be beneficial in some contexts. But at the moment, it's all a bit sort of undefined, isn't it? A lot of these therapies are given, and it's, as someone with a scientific background, I really like to see a robust demonstration of how this might be working and what's really going on, rather than it being promoted as a sort of a magic elixir that may be useful. And I think this is one of the issues that's been perhaps undermining the platelet-rich plasma approach, is that there've been so many studies of different approaches without clearly a good animal model to understand what's going on in the ovary. And indeed, we now have an RCT of platelet-rich plasma from the Semery Emily and colleagues in the US, which didn't show a benefit. Now, I suspect that's not going to be at the end of it, because people, I'm sure, will think, well, maybe there's a different ways because they had a certain way of doing it, and maybe you need to do it more repeatedly over a long period of time. There are lots of different approaches that might still have benefit there. But I think what I think is really important about that study was it did show that you can do straightforward RCTs of that type of approach. And the number of patients involved, I think 83 women were included in that RCT. It's not much bigger than a lot of the uncontrolled studies that have been published that support a benefit. So I think that people really need to make sure that there's robust evidence here and do the studies well. And if they can show it's beneficial, then everyone loves it. It's a win-win, isn't it? It's fantastic. But if it isn't beneficial, then we need to stop doing it and stop misleading our patients that it helps and move on to find something that does work.
I totally agree with you, sir. Till now, we should be calling it only under research, because we still don't know many. There are many unsolved puzzles in which patient it will work, how long it will work, when the results will start seeing. There are many unanswered questions over there. But we do understand that the stem cells, they are capable of self-renewal. They can differentiate into particular tissue in response to the environment or the signals. And there are many signals which goes, and the cytokines, the growth factors, the regulatory factors, all together, I feel biggest advantage also is it causes neoangiogenesis and all. So probably
It's a
more
fascinating
and
area,
more.
isn't it? Yeah. I think
Yeah,
you're quite right. I mean, some of the data in so human xenografts of using this approach with bone marrow derived stem cells did focus, as you say, on whether neoangiogenesis might be valuable to help support those follicles. Because of course, one of the problems of the ovary from our point of view of trying to get it to work better is that it's a very wasteful process, isn't it? Normally, you might start in a normal young woman's ovary with 10 follicles every day starting to grow, 300 a month, but yet only one is going to be ovulated. And if we could support all the ones and improve them that actually fall by the wayside, then that might be fantastic. But I think your comment raises so many interesting questions about what else is going on, not just the follicle, but the stroma around the follicle that's going to support that. And angiogenesis is one aspect of that. But we're now understanding much more
it is
about what's
also,
going on in the
they
stroma.
say, I agree. They also say that TGF beta signaling, the antifibrosis happen, immunomodulation, anti-apoptosis, for induction of a folliculogenesis. They have found so many signals going on. So I think more and more research probably will make us understand. I do stem cells for a selected patient a lot, especially the patient who are just not ready for a third party reproduction. And what I feel is it's very unpredictable in which patient it will work, when it will work. So unless we have the concrete answers of these, and that will come only when our understanding about how the stem cell function, how they improve the folliculogenesis, how we are going to retrieve the eggs out of this lady who has such a low egg reservoir. We will have many.
And I think the other aspect of that you allude to is, of course, we need to consider what actually is the pathology going on in one patient versus another.
Absolutely.
And of course, we have a bunch of genetic causes that may be affecting the fibrosis of the stroma. We have aging effects going on as well that are more important. And there may be, of course, there's a lot of our patients have had chemotherapy previously that all these things will have different impacts on
It
the
will not
ovary to
work
underlie
on.
the pathology. So it's not one treatment is going to work for each pathology. I think it's a matter of identifying what's going on for that patient and that group of patients and working out what's best for them.
I agree with you, sir. Definitely, Fragile X syndrome or XO, we should be ensuring that before we take this patient that they don't have these genetic disorders. But it was wonderful talking to you, and we thank Aspire for giving an opportunity for both of us to meet each other, have a healthy dialogue, and knowing you, sir, and your work on this POI, I really cherish those moments, and it's wonderful to be in one frame with you.
Thank you very much. It's been a pleasure to have this conversation with you. And again, thanks to Aspire for hosting it and to making it happen. And I look forward to speaking again.